All right, so I had ACL repair for my clinical pattern, and this is using patellar tendon grafts, hamstring tendon, and allografts. So the surgical procedure, ACL repair happens with the patient under general anesthesia, and is completed through 3 to 4 small incisions around the knee. One incision will be for a small camera to visualize the joint, and others are made for the surgical instruments to access the joint. First, the surgeon will remove the damaged ACL and obtain the autograft tissue from either the hamstring or patellar tendon. And if they're using an allograft, obviously this step wouldn't be necessary. They would already have it from a cadaver. Then one tunnel is drilled into the femur and another into the tibia in order to make a space for the new graft. The tendon will be positioned between the tunnels, and screws are inserted into the drilled spaces in order to hold the new ACL in place. And the tendon graft serves as a scaffolding on which the new ligament tissue can grow. And there's different advantages and disadvantages to each graft, and you can read more about that in the written template. But basically for patellar tendon, they're just going to take the middle third of the patellar tendon as the graft. For hamstring tendon, they usually either use semitendinosus or gracilis or both, and allograft is obviously from a cadaver. So this is hamstring. ACL tears usually happen in the age group of 15 to 40. The male incidence peaks around 19 to 25 years of age, and the female incidence peaks around 14 to 18. Women are about 2 to 8 times more likely to sustain an ACL injury. For outcome tools, you can use hop testing, which is single leg, timed, crossover, or triple. You can also use isokinetic strength testing of the knee flexors and extensors. For the mechanism of injury, most injuries are non-contact and occur during sports that involve maneuvers such as sudden deceleration, an abrupt change of direction, speed or velocity, pivoting with a fixed foot, landing from a jump with the knee hyperextended. And a twisting injury can also occur, which is when the knee is in full extension and the femur is externally rotated on the fixed tibia. And when a contact injury is the cause, it's usually from an excessive valgus force applied to the outer aspect of the knee joint. So need for systems review, I would say yes, only if you think that something else is going on, since this usually occurs in the younger athletic population. You probably don't need to do one unless you think something more serious is going on with them as well. For precautions and contraindications, so don't perform ACL stress testing initially, and don't include activities in treatment that involve cutting, changing direction rapidly, or slowing down abruptly. At least at first, don't do that. And then in general, for all of the grafts, no showering or bathing until suture removal. The brace has to be worn when sleeping and locked in extension for a week, and that goes for ambulating as well until the patient has full knee extension and good quad control. There are driving restrictions based on which leg it's on. Usually their weight bearing is tolerated immediately post-op. They have to use crutches and a brace for ambulation, and they can be weaned off when the patient has normal gait mechanics and quad control. They should avoid hyperextension greater than 10 degrees, and there's no full weight bearing running until about 12 weeks. And then additional contraindications and precautions for hamstring tendon grafts. They may have a longer fixation period. And then in phase 1 of rehab, only do flexion to 90 degrees in order to protect the graft. Active assisted range of motion for leg curls for a week, and then you can progress it to active range of motion. There's no resisted hamstring activities or strengthening during the initial rehab phases, and you're limited to very gentle hamstring stretching for about 4 weeks. Any differences for allograft? The weight bearing status could be a little bit different. It could be touchdown weight bearing or partial weight bearing instead of weight bearing as tolerated. And you also want to avoid hyperextension of the knee. And revascularization could be slower for these people. For the physical exam, you would expect to see small incisions around the knee, and you should note how they're healing. You may see swelling in the involved limb compared to the uninvolved, potentially leading to quadriceps inhibition. You may see redness, quadriceps atrophy, and they probably will have an impaired gait pattern since they're partial weight bearing or weight bearing as tolerated. For active movement testing, you would expect decreased active range of motion of knee flexion and extension initially post-op. And the goal from post-op to week 4 is to regain full active and passive knee extension range of motion, but avoid that hyperextension. For passive, again, expect decreased passive range of motion of knee flexion and extension. There's no resisted testing, just see how they can activate their quads. No accessory testing, neurodynamics, or special tests, but with palpation, you may find atrophy in the quads, and you may see or feel joint effusion in the involved knee. For diagnosing an ACL tear, an MRI is usually used, or arthroscopy. And then signs and symptoms to referral to a physician, evidence of a DVT or PE, loss of sensation or motor function in the leg, signs of infection, increased knee pain or stiffness, or poor healing of the graft and not following the anticipated timeline.